everything's great at home. We are fraternal, but she's also a neurologist, but she's into seizure specialty, so she's on the inpatient side of things. So to recover, she's in Omaha, you know, see, yep. She moved to Milwaukee for a little bit, but now she's back. We love having friends. Yeah. So my older sister specializes in so she yes, it's a very difficult job, very interesting. So what she does, it's just so amazing how niche of subspecialty
Being recorded.
Yeah.
Hello, everyone. We're so excited to see all of you. And we're excited to have Dr. Smith with us today. Many of you know her and appreciate her, and you've heard her speak some other times, and it's always been great. So we've invited her back today. On the table, I didn't think something for everyone. If you want to see this, you can go to the website. That's where I saw it. But it's really fun. She's a twin. Hey, you brought twins.
I did. Good afternoon, everybody. I'm seeing some familiar faces. Thank you, Joyce, and thank you, Rich, for having me. I brought a couple of people from UNMC who are hiding in the back. They're probably not expecting me to call them out, but Dr. Miguel C2 is probably some of your neurologists. And then one of our new fellows, Sandy Antigua, is here as well. So you may have met her in the clinic already, and if not, you will. But I'm good to go. Good to start. Okay, thank you, Joyce. And so again, thank you for having me. I'm Erin Smith. I'm one of the movement disorders neurologists over at the Med Center at UNMC. I am a lifer at the Med Center, so I did my medical school, my fellowship training, and then now I'm faculty, and I've also taken over the fellowship training program and a lot of medical student education there. But as many of you guys know, my primary love and what I do is Parkinson's disease. So all of you folks here. And I have a couple of things I want to talk to you guys about this afternoon. Everybody is okay with my volume? Everybody in the back in here, I'm giving the thumbs up in the back. I appreciate that. Okay, sounds good. So for today, I'm going to cover kind of some just overall therapy in Parkinson's disease, and that's going to range a couple different directions. So I'm going to spend a couple minutes talking about why treating Parkinson's is hard. You know, what are the challenges that we encounter when we are treating all of you guys and all of your different states of disease, all your different specific symptom problems that you have with this. Talk about what we're doing currently for Parkinson's, including some of the newer stuff that's come down the pipeline in the clinic. So that's going to include things like our newer long-acting capsules, our continuous infusion pumps, things like that. There's an awful lot of information and misinformation out there when it comes to Parkinson's disease treatment as well. So I'd like to cover what I call kind of the hot topics. You know, what are the things that we're talking about on the street, or so-and-so said they tried this for their Parkinson's, you know, does it actually work? We're going to talk about a little bit of that stuff. And then I was also asked to talk a little bit about the role of Botox in Parkinson's disease. So not just for cosmetic purposes, as you guys will find out this afternoon. So you may have asked me this question in the clinic. If not, I get asked it probably at least once a day. When are we going to finally find a cure for this thing? And I wish it was that straightforward, but it's truly not. And so part of the problem with Parkinson's disease and its treatment is that it's really hard to get to the root and the bottom of it. There's not just one root that we can yank and that we've figured it out and we've cured it. It has a lot of different roots and directions and causes of Parkinson's disease. And every person that has Parkinson's disease is also affected by all these different causes in different ways. So we don't really consider it to be, you know, like an inherited or a family disorder necessarily. We still think that 90% of cases of Parkinson's are not genetic, but there still are genetic types of it, and there still are genetic variants in each individual that causes it. So awfully hard to figure out a treatment that fits everybody in that way. We know that Parkinson's is also just part of natural aging in the brain. So, you know, if we all live to be well into our hundreds, we would actually all get some degree of Parkinson's. But there are reasons why some of us get it, some of us don't, that we don't completely understand. We know that there are environmental parts to it. So we have a lot of it in the Midwest due to pesticide exposures, what have you. I like to say quite literally, it's in the water here. There's something about it that a lot of people in the Midwest will develop Parkinson's. So certainly an environmental part of it. Some parts of it that we say there's just something going on in our cells with each individual. And then again, just so much of it that we still don't know. So as you can imagine, it's awfully hard to come up with one specific treatment that addresses all of those things and cures this disease. I consider Parkinson's also kind of hard to pin down in the sense that if you meet one person with Parkinson's, you've met exactly one person with Parkinson's. And I'm sure as you folks, have met each other, interacted with each other, and looked around the room, you have also noticed that everybody's journey with this is just a little bit different. We also don't really have what we call biomarkers in our clinical practice. And so by that, I mean, we still diagnose Parkinson's disease clinically by looking at you. So we talk about the symptoms you're having. We do your exam, and we actually don't use really, pictures of your brain or blood tests or anything like that to make the diagnosis. It's still very much based on us looking at you and doing your exam. And so markers are things like a blood test or, something that confirms it for us. And we just don't really have anything like that yet, although it's certainly in the works. So we don't really have anything like that that makes that diagnosis efficient, that gives us a sense for how they are safe. So that's why I say disease progression there. We don't have something that says, oh, you are, in the middle stage of Parkinson's or in the late stage. That still is a pretty subjective measure. And then we also don't really have a good way of saying that you're responding to treatment other than asking, do you think it's working or not? We don't really have a way that we say, okay, there's less inflammation now in your blood, so we can tell that the medicine is working. We don't have a measure for that. So that's just yet another challenge that we face when we're trying to really effectively treat Parkinson's. Look, we have this little thing that I'm sure that a lot of you folks have seen before. We call it the Parkinson's disease iceberg. And by that, we mean looking at you, we only see the very surface of what's really going on with you. So a lot of people know the physical symptoms of Parkinson's. We see things like tremor, we see things like slowness, stiffness, that kind of lack of facial expression. But what we often don't see is all of these things that go on beneath the surface that I'm sure as you look at these, you're checking some of these boxes off. Just like speech issues, anxiety issues, change in appetite, weight loss, sleep issues, memory issues, all of that kind of stuff. And so if you met me in clinic, I have said to you that Parkinson's leaves no stone unturned, and that's because it really does. It affects all these parts of your life and all these parts of your body. And so, as you can imagine, everybody also has a different degree to which these various symptoms bother them or affect them. So how can we possibly take one treatment regimen and expect to apply that to every single Parkinson's patient that we meet? We really can't. The treatment for Parkinson's is also complicated by itself because the longer that you have Parkinson's, the more likely you are to develop issues just from the treatment itself. And so that's going to be things like what we call these motor fluctuations. And I'll talk about those a little bit later. Also the side effect that some of you I'm sure have experienced called dyskinesias, kind of the extra wiggly movements that I call them the Michael J. Fox movements because he's kind of the poster child for those. And then of course, the treatment of Parkinson's is also just in a social level very complex. We have people that are still at a place where they want to try to remain gainfully employed or they end up having to file for disability earlier than they had hoped. Has big social, financial, and economic impacts on people that you really just can't measure, and you can't really use a medication to treat or address. And so this is the kind of long-standing gold standard that we have for Parkinson's disease, which is levodopa. So levodopa has been established since the 1970s. It is still considered the best medication that we have. It is called carbidopa, levodopa, or you guys I'm sure have seen these brand names out there. Sinemet is probably the most common, but some of the newer ones that it's marketed as can be Rytary, Crexont, Duopa, Vylev, and Bresia, and the list goes on. So a lot of different names, and I'm going to break down some of these different formulations as well. But what is levodopa? How does it work? So we know that levodopa works because it's kind of part of your brain's ingredients to make your dopamine. So people with Parkinson's, their brains are having cells that make their dopamine dying off over time for various reasons. And so levodopa kind of helps you make more of that dopamine. And so kind of just works in that pathway to make it. It does cross over from the blood into the brain, this thing that we call the blood-brain barrier. And pure dopamine can't do that. So that's kind of why we can't just give you dopamine. right? It seems so easy. You don't have enough dopamine, let's give you some. It's not that simple. It doesn't cross over into your brain. But the main side effect that we run into with levodopa is nausea. And so that's why if you look at your pill, it says carbidopa levodopa, because carbidopa is intended to block levodopa from becoming dopamine in your gut, and which causes a lot of nausea. So that's why the pill is built that way. And so carbidopa and levodopa together are marketed as Sinemet, which if we have any Latin nerds out there is Latin for without emesis or without vomiting. So it kind of just keys to that side effect of nausea. That's the most common. This might be a little bit difficult for some of you in the back to read, but I'll kind of break it down by section here. This is supposed to be a little bit dizzying in the sense that these are just all the different types and forms that levodopa comes in. So, here over on the left side, we have what were our oral ways that you take carbidopa, levodopa, whether it is in a tablet or a capsule form. We have two tablets that we use kind of generally. We have immediate release and controlled release tablets. And then we have these different capsules that are now available that I'll chat with you guys about here in the coming slides. We have Rytari and then the newest that's called Crexont. We also have what are called rescue treatments or rescue forms of levodopa. So it actually comes in a powdered inhaler form that some of you here may use too. That's called Ambrosia. And then we have our continuous infusion treatments for our pumps. And so we currently have two of those that have levodopa. One of them is called Duopa, which is the one that requires a feeding tube. And then the other one that's the newer one is called Bioleve. And that one is what we call subcutaneous. And so it can be delivered under the skin. And I'll have some pictures and I'll go through each of these individually. So levodopa has it's good in its bad sides. Actually, when levodopa first kind of came out, we were so happy with it because we finally had something that helped people with Parkinson's, and actually mortality rates significantly decreased. And so people with Parkinson's then were able to have a normal life expectancy. We didn't really need to do anything as invasive as surgery right away, even though I'm sure some of you have had the surgery. We're not going to talk about that as much today. But in general, levodopa, as it's marketed as a Sinemet, works pretty well for most people. It helps, at least initially, it adds the right dose. Pretty well tolerated in terms of side effects, as long as your neurologist or your primary care doctor starts it as a nice low dose and works your way up so you don't get those side effects of nausea. Tends to play along pretty well with other medications, which is good if you've got a growing list of medications. I say it's a benefit to not have a one-size-fits-all regimen to it because people can kind of be flexible with how often they dose it, with how often they need to take it, or how much. Some people, I'm sure some of you here even use the tablets kind of as needed, like some extra throughout the day. And so there's just a lot of different ways that you can slice it, a lot of different ways that you can use it. And so those are kind of the good sides that we deal with of our levodopa. But over time, some of you may have experienced this already, that the longer you have Parkinson's, the less of those dopamine making brain cells that you have. And so naturally you have to keep increasing that dose over time. So people usually need to be on higher doses. And that can often be limited by side effects. So whether people have nausea or blood pressure fluctuations, or even may have things like hallucinations or things going on that may get worse as you increase this medication. The dosing of it is already fairly frequent as it is. We typically will start it 3 times a day, which for some folks I've met that don't have a very long medication list, going from no medications to suddenly one that you're taking 3 times a day or more can be a little cumbersome, can kind of take over your schedule a little bit. A lot of you here know that levodopa also interacts with protein in your diet. So if you take it at the same time as you have something rich in protein, it's going to compete to get absorbed in your gut and will make your tablets not work as well. So you have to be really cautious of your timing with your protein exactly. So that can become cumbersome as well. You don't get to just decide to go out to dinner. You have to think about, oh, what time are my medications and those types of things. And then the longer that you have Parkinson's, you are more likely to get more side effects from levodopa. So those can be things like hallucinations, impulse control problems, those wigglies, those dyskinesias, and then what we call these motor and non-motor fluctuations. And so what I mean by that, so motor fluctuations are when, let's say that you have a tremor, maybe that's your primary symptom of your Parkinson's. You notice that as you take your carbidopa, levodopa, that you can tell that tremor is coming back sooner than you're due to take your next pill. And so you kind of feel like your day is spent feeling really good when the pill is kicked in, and then getting that tremor or other symptoms coming back, and you have like an hour or longer before you're due to take your next pill. And so your day just kind of ends up being a roller coaster, just not very predictable, not very smooth. People can have non-motor fluctuations as well. So people can actually develop things like anxiety, or just feeling sleepy, or anxious, or get all sorts of things, even not physical symptoms necessarily. Sweating actually is one I'm going to tell you guys about later. So all these goofy things that you can experience that are uncomfortable between the doses of your pills as well. And so that's where some of these other formulations of carbidopa, levodopa come in. So the one that we've had around for a while, about 10 years now actually, is this capsule that's called Rytary. And so Rytary is the same medicine. It's carbidopa, levodopa, but it's in these capsules that have 1/3 of the immediate release or the short-acting medicine. And then the other 2/3 of the capsule is extended release medicine. So you have a little bit that kicks in right away, and then a little bit more that kind of takes a little bit while to burn. The capsule comes with these little microbeads inside of that medication. So for some people, that allows them to just kind of smooth out the experience of their day. It doesn't quite kick in the same way that the tablets do, but it does kind of just lead to just a smoother ride. So instead of kind of going up and down all day, you kind of get just a more predictable and consistent response from your medicine. And that's kind of the goal of where a lot of these other treatments or variations of levodopa, if that's what the goal is that I'm kind of leading into. Crexont is from the same folks that made Rytary, so I kind of think of it as the new and improved version of Rytary. So that just came out this last fall. Similar idea. So it is also a capsule that has little microbeads inside of it. Has a couple different doses, but again, still has that some immediate release and some extended release inside the same capsule. So the idea of just making things last longer. And actually some people who were taking the regular Cinemet tablets were able to get away with taking Crexont quite a bit less frequently. So in the clinical trial, folks that were taking these Cinemet little yellow or white tablets 5 times a day were able to take Crexont only 2 to 3 times a day. So you can see how that kind of makes life a little less complicated as well. The leg up that Crexont has on Rytary is that their beads have an extra little feature or ingredient called a mucopolysaccharide that just helps your gut to hang on to the medicine just a little bit longer, even a little bit longer than the Cinemet, but also the Rytary. So that's why I call it the new and improved version of Rytary. Now, of course, cost is always going to be an issue when it comes. Anything new and shiny is always going to potentially have a higher price tag. But so far, at least the company has said that it's a little bit less expensive than Rytary. And so, if you're someone out there that is taking your Cinemet tablets, 3, 4, 5 more times a day, one of these capsules might be a good choice for you. I do just want to be clear, though, that no matter what form of levodopa that we're dealing with, whether it be a tablet, a capsule, what have you, the same side effects are still going to apply. So we can still get things like nausea, dizziness, low blood pressures, hallucinations, all those things, and the same protein limitations apply as well. So same thing with the capsules. If you take them at the exact same time that you have a bunch of protein, it could make those capsules less effective. And so, every neurologist that you ask will probably have a little bit different on range for this. I tell my patients, if you can give your tablets or your capsules at least a 30 to 60 minute head start, or wait 30 to 60 minutes after you have protein, then you're doing pretty good. But you're also out in the real world where, like I said, sometimes you just want to go to dinner on the fly. And so it's not always realistic to live your life like that. And so a couple more advanced things have been developed. And so that's where I'll tell you a little bit about these pumps. The pump that we've had available now for a while that is called Duopa, that is an intestinal gel. And so the medicine actually gets given through this feeding tube that goes into the gut. So it does require a feeding tube that is a minor surgery. And the medicine is in a cartridge in a gel that you hook to the bottom of this pump. And I tell my patients, it's kind of like you're just licking on a tablet of your Cinemet all day. So instead of taking a dose, every couple hours, you don't need to think about taking pills. You get the medicine infused directly into your gut as a gel. The company website also has this little picture off to the right that shows that little itty bitty levodopa pill, that yellow tablet stuck in the stomach after somebody took it. And that is just to demonstrate that a lot of people with Parkinson's also just have gut issues, whether it is gut motility problems, just slow getting stuff to push through, or you're just not absorbing things as well, whether that be pills or nutrients. And so getting it a little bit further down the pipe directly into the intestine really helps to bypass this whole system and can help people absorb the medicine a lot more effectively as well. The downsides of the Duopa pump, I tell my patients if we're considering this, the Duopa can get kinked, clogged, yanked, infected, pretty much anything you can imagine a tube or a pipe can do, it can do that. If it does become dislodged, usually it's a fairly minor thing. We just have people go back on pills while they wait to get the tube put back in, but it does require a minor procedure again to get that tube put back in. So it has some of its own issues here and there, but otherwise, in terms of benefit and consistency and how the medicine is working, can be very effective for that. So one kind of improvement that now has been made is this newer pump that we call subcutaneous. So rather than needing a feeding tube to infuse the medicine, it actually is in a little needle that pokes into the skin. So that's what this middle picture of this first belly button is. So that's just showing this little needle. And underneath it is an itty bitty little needle that pokes under the skin and gives the medicine under the skin. So it takes the gut and the GI system completely out of the picture, which for some people that have a really slow gut or that have a lot of issues with dietary interactions and the medications, can mostly circumvent that. So it's a pretty big benefit. The pump itself is a little bit smaller than the Duopa pump. So they say it's usually about the size of 2 cell phones stacked on one another. And they have a bunch of different carrying devices you can use with it. So they have this kind of more like a lap, kind of fanny pack situation. They have like a kind of a crossbody or a vest. So different ways that you can have it to hold close to your body. One issue that's come up for a lot of my very active patients is they don't love the idea of having a pump or something physically connected to them while they're trying to exercise or, garden, getting up and down, those kind of things. And so the company has worked hard to try to make sure that those pumps feel nice and secure and stay where they're supposed to. And so this is another look at what that pump looks like. So the person's wearing their pump. The medicine itself comes in a syringe that you just put inside the pump, and that can actually infuse medicine either just kind of during your waking hours, like 16 to 18 hours during the day, but it actually also has the option to have it overnight as well. So some people will run these pumps for 24 hours, which if you're one of those folks that has trouble with getting up overnight to go to the bathroom, or like when you get up in the morning initially, you feel extra stiff or slow, or you have more tremor because your medicine's all worn out of your system, that can be a big benefit to having some medicine just in your system all during the night. The main issues that have come up with this pump so far is that some people can get a little bit of irritation where that needle goes in. It can form these little bumps or kind of just scarring that we call nodules, and that might make it difficult to poke the needle again in there for a future site. Usually people do switch those sites every day. So a lot of people will kind of do a little zigzag form on their stomach, just kind of put the needle somewhere different every day. Sometimes the medicine can leak a little bit as well. Usually that's because we haven't poked the needle in far enough, and so that's usually just a technique that we can show you how to do a little bit more effectively. But again, the same side effects apply. So it certainly can still have nausea, blood pressure issues, dizziness, hallucinations, those types of things can still come up. And actually we have noticed that people still find that around the times they eat, especially with protein, that they may notice it not be as kind of potent, but the interaction with the diet with protein in particular is much less. And so, like I said, especially for those people that are very sensitive to protein in their diet with their medicines, it can be a really nice option to really offset that problem. I wanted to highlight another pump that we have available. So this is not a levodopa pump. This is a completely different medicine, but it still is one that we use in the treatment of Parkinson's disease. It's a medicine that's called apomorphine. And for anybody that is not familiar with apomorphine, it's just a way of kind of giving dopamine a little bit more directly. It doesn't have any morphine in it, so there's no pain medicine involved in it. It has the word morphine, but it's not morphine. And it's not one of those pumps that would replace your pills completely. So a lot of people still take pills with it, but they do find that it helps to reduce those fluctuations, those kind of peaks and valleys in their day. And for folks, especially that have a lot of the dyskinesias, this pump can really help with that. It is covered by Medicare. It is a little bit smaller yet than the Viley pump. And so for some people that have a concern about a big device that they have to put around everywhere, it's just an option to consider as well. So I wanted to highlight that. That one just came out in April of this year. So really hot off the press and just kind of started to roll it out in the clinic a little bit. Okay, so let's talk about the word on the street. What have people been talking about? All these articles coming out on Parkinson's today and on the news and those kind of things. So one of them I wanted to discuss with you folks today are the diabetes and the weight loss drugs. They're a class of medications that we call the GLP-1 agonists. And so there's been a couple different articles over the last couple of years saying, can we use these things, usually marketed as Ozempic or Mounjaro or Wegovy? Can we be using these, hot weight loss drugs to help with Parkinson's? The idea behind it is that these medications help us to trigger insulin in our bodies. And so they help to treat diabetes, and they also help to regulate hunger and weight, so promoting weight loss. And we also have these receptors in our brains. And so it's thought that these medications may help to reduce brain inflammation and help not only with degenerative diseases like Parkinson's, but also like Alzheimer's and other brain issues. And so these have been looked at for a while. I do just want to be clear that the current kind of trendy marketed ones, the ones that you see the celebrities using, like Ozempic, Mounjaro, and Wegovy, they do not cross over into the brain. So those specific medications do not work for Parkinson's. What are being studied are kind of some similar medicines that do cross over into the brain. And so one of these drugs is called exenatide. It's, again, the same class of medicine as Ozempic, Wegovy, those medicines. And we've now been able to watch these folks over a longer time period, about 2 years. The latest article from earlier this year in February determined that they really did not see a big difference in disease progression between those who were taking these medications and those who weren't. Now, there's always going to be a big caveat with any research study. Did we pick the best people for this? What medication regimens were they on? We've already established that every Parkinson's patient is so different, right? So, there's always going to be some margin for, is our data as clean or as good as it could have been? And so I would not completely discount these types of medicines yet, but we still have a bit more time that we need to be looking at them before this is going to be a treatment option. I get asked about stem cell therapy pretty frequently in the clinic as well. So I wanted to highlight that one today too. And the idea behind stem cell therapy is that if you are someone with Parkinson's and your brain cells making your dopamine are dying off over time, why wouldn't we just grow new dopamine cells and put them in your brain? That seems pretty straightforward. Well, of course it's not, right? Nothing in Parkinson's is straightforward, but essentially the idea is that we do give these new brain cells whose job it is to make dopamine cells in the future. We call them these precursor cells. And maybe they would work to help to reduce inflammation in the brain, maybe restore some normal brain cell function and promote new dopamine brain cells. So kind of like a Parkinson's in a petri dish is what we call it. And so the idea is that it wouldn't necessarily, get to the root of the problem. It would not stop those brain cells from dying off in the first place, but at least it can be used as maybe a symptomatic therapy. So still very much something that's in progress here, but it's kind of a model right now that we can kind of mimic Parkinson's in the lab and use to see how these treatments might work, but maybe have other, model Parkinson's to try out other treatments as well. And so the limits so far, it seems with the stem cell therapy trials have been that we haven't really found what dose is going to work, especially finding a dose that's high enough to be effective without bringing on side effects. So you can still get the same side effects like nausea, dyskinesia, the whole thing. So we don't work around that issue. If you've ever met anybody who's had a transplant before, you know that sometimes your body can have a reaction or something that's what we call like transplant rejection. And so the same thing also applies to that. So you have to be very careful who you're giving these stem cells to. And so this is going to continue to be studied. It actually is becoming pretty promising, I believe. And so I think it is something that will be up and coming in the years ahead. But I do put the disclaimer here that some people are marketing stem cell therapy for different neurologic diseases just out in the world right now. It is currently not an FDA-approved therapy for Parkinson's disease. So just be kind of careful out there when people are marketing this kind of stuff. This was kind of a hot topic a couple of years ago. I wanted to bring it up again because some newer things have gone on with it. But if anybody was watching Good Morning America in December of 2022, you would have seen this story. There was a gentleman who had really severe Parkinson's disease, a lot of tremor, horrible freezing up while walking. And he straps on these little babies, these gloves here, and then he goes off and he runs a marathon. So it was pretty attention grabbing, understandably. And so there are these gloves that this neurosurgeon named Peter Tass was studying out at Stanford Labs. And it's interesting because it's actually kind of an old concept. So back in the 19th century, excuse me, one of our really old neurologists, a guy named Charcot, noticed that Parkinson's patients who were either on a long horseback ride or a long train or carriage ride would get off the train or carriage or horse and they would feel like their Parkinson's symptoms were better. And so he was trying to figure out what was it about those things that made Parkinson's better. And the idea was, is there something about the vibration, about the movement that makes Parkinson's people feel better? And so he developed this chair that's pictured here. Looks kind of like a torture device, if I'm being honest, but you know, it's an old picture anyway. And so the idea is that this chair would vibrate to kind of mimic like a really bumpy train or carriage ride. And so that's the idea. Actually, some of the neurologists out of Rush in Chicago did something similar. This has been almost 10 to 15 years ago now. And they put people with Parkinson's in these vibrating chairs, and they either also had them listen to nice, relaxing nature sounds or no music, no sounds whatsoever. And it seemed that people did about the same either way. It didn't really matter if they had the vibration or not. It seemed like maybe just sitting in a chair and listening to relaxing music was helpful. And so, you know, that I can recommend to you, but otherwise, it seemed like, you know, it wasn't the vibration of the chair itself is what the conclusion was drawn. And so these gloves are still being studied. Actually, people have looked at vibrating socks as well. You know, if you have gloves that can vibrate, why can't you put on socks that can vibrate? Sure. But these studies are still recruiting. They have on their website, you can sign up to be parts of their future studies. And then some other states, like over in Oregon, they're picking up on this and looking at very similar design of gloves. So earlier this year, there were actually some students at Rice that developed using a 3D printer, these similar gloves. And I just wanted to include this because they're a lot more cost effective, a little bit less expensive. And so they actually do have this website where they're selling these gloves for people to try. And again, like I said, they made them in a 3D printer. They're only like, I want to say like $200 or something, which I think is still kind of expensive, but compared to the other ones, much less expensive. So kind of just interesting. It's something that's still going to be out there. Doesn't, you know, very few side effects involved other than maybe looking a little silly, but that's it. A couple more hot topics for you guys. This one's been around, kind of talked about for a while. It still is, will continue to be, is can we use marijuana, CBD products, and how do these play into Parkinson's disease? And so I know this is going to be kind of hard for some of y'all in the back to read, but there was this paper back in 2021 that was called Weeding Through the Haze, a survey on cannabis use among people living with Parkinson's disease in the US. And they surveyed people in 49 states, and actually about a quarter of people reported use of cannabis of some form, whether it was smoking it, whether it was an oil, you know, oral, top, whatever. And a lot of people did report that it helped with a lot of symptoms that a lot of you guys struggle with. So it helped with sleep, helped with anxiety, helped reduce tremor, helped with pain, you know, a lot of things that a lot of you guys here in this room experience. And so something that seems to help and is being used. Studying it is kind of challenging because it comes in so many different forms. And so even though we know that it may help with things like sleep and tremor, side effects from medicines, it's hard to be consistent with using it in the same form or same doses. And it's also kind of hard to measure other than subjectively what's improving. So we just don't have enough information on this yet. There was one study that looked at people over a 20-year period. So that's a long time. And they at least established that use of any kind of cannabis products did not slow or did not make disease progression go faster, so had no impact on disease progression, which is an important thing. And one concern that we had too is maybe it could make like memory worse or things like anxiety or psychosis, hallucinations, or like paranoia, those types of things can make worse, but it didn't. So we can at least establish that it's not a harmful thing necessarily. And so this will continue to be studied, trying to just find universal forms, doses, and those types of things, and seeing how it can be useful as symptomatic therapy for things like tremor, sleep, and a bunch of these more non-motor things as well. Another topic that has come up relatively recently, actually it's kind of old and then it's reared its head again more recently too, are nicotine patches. And so what is the idea behind this? What would nicotine have to do with Parkinson's disease? And so we've known for a long time that people that smoke are less likely to develop Parkinson's disease than people who don't smoke. And there's been a couple proposed mechanisms behind that. There's a thought that maybe nicotine itself just protects the brain cells. Maybe it helps to reduce inflammation in the brain, or maybe it helps to stop brain cells from dying. These pictures over here on the right are just to show you the many articles and studies that have been done on this. And so the thought was that we could stick a nicotine patch on people and let's see if it helps or if it at least slows down disease progression. And so this paper is already a couple of years old. It's back from 2023 already. But at least at that time, they established that it did not seem to slow down Parkinson's disease. And in fact, a lot of people ended up having side effects from it that are common of nicotine patches. So people would get like some skin irritation, or they get really like jittery or nauseous, headaches, interrupted their sleep, those types of things. And so I do just want to be clear that right now smoking cigarettes is not recommended to prevent Parkinson's disease. So don't stop at the store on your way home and pick up smokes. Certainly the risk of smoking is much higher than the benefit that it may give you, so I don't recommend that. But what we are kind of realizing is that maybe we don't really understand the mechanism behind why smokers are less likely to get Parkinson's. We need more studies just to understand that on a cellular level before we go using it as a treatment option. So we don't know, maybe it's something else that's in cigarettes that has something to do with it. One interesting theory that was pitched was maybe it's more of a lifestyle choice thing. I don't know if you guys have noticed, but it tends to be that awfully nice people get Parkinson's disease. They tend not to be, big risk takers, and engage in risky lifestyle behaviors. And so that's just kind of the generalized thought that maybe, people, maybe because they don't smoke, that's why they are getting Parkinson's. Who's to say? I don't know. Lots of thoughts on that. Kind of an interesting idea. The very last thing I want to talk to you guys about is highlighting a treatment that we've actually had available for people with Parkinson's for a long time, for several different reasons. And so this is something that not everybody knows exists or that we do, or maybe you have met somebody. But I want to talk to you guys about what Botox has to do with Parkinson's disease. And so first of all, I would like to take you through what Botox is exactly. So believe it or not, Botox is actually a bacteria. It's a bacteria that's called Clostridium botulinum. And you find it in undercooked meats or improperly canned food. And those things produce this neurotoxin, this brain-acting toxin called botulinum toxin. And that's what causes botulism. And so some of you may be familiar with botulism. Thankfully, we don't see it that often anymore. But it's a condition that causes muscle weakness and paralysis. And it can paralyze the diaphragm as well, which leads to difficulty breathing and can be a very serious condition resulting in death. Back in the 1800s, we noticed that it was in a lot of spoiled sausage. And so this name botulism is actually derived, again, for my Latin nerds out there, from the word botulus, which means sausage in Latin. So that's where botulinum toxin came from with its name. When very, very, very heavily diluted, Botox actually can work really well as a medication. It's always so interesting to me, who were the first people that decided to try this out, and who were the first people that were willing to have this tried on them? I imagine that there was probably a lot of trial and error along the way. But today in our modern times, Botox is actually used for a whole variety of different things. A lot of you guys already know, we use it for cosmetic reasons, fine lines and wrinkles. We actually use it as a migraine preventative. Some people that have eye twitching disorders or face twitching will use it for muscle tightness after a stroke. People will use it for vocal cord issues, overactive bladder, all sorts of things. And so where does it come into Parkinson's disease? So there's actually quite a few ways that we can use Botox to help with Parkinson's disease. There's a lot of physical symptoms. So some of you out there may have what we call cervical dystonia, which is posturing of the neck. I'll show you guys some pictures, or pain in the neck from just sitting in the same position or being stuck in a certain position. People can have dystonia of the limbs as well, most commonly the legs. You can have it in the back or the trunk. Actually, we'll sometimes use Botox sometimes to help with tremor. If we've had a lot of trouble with side effects for medications and you're still having a lot of tremor that bugs you, I've tried it for that too. And then we also have some non-motor symptoms we'll use it for. A lot of people have too much drooling, too much sweating, or also have overactive bladder. So it can be used for all of these different things. Here's a picture of what we call neck or cervical dystonia. And so it can be more subtle than this, or it can be this obvious as well. People will find that their muscles are just wanting to pull in a certain direction, whether kind of off to the side, most commonly kind of forward. That's why a lot of people with Parkinson's kind of stoop forward. Or it can just be more pain, just muscle pain, spasming up in this neck and shoulder area. And so we will inject Botox into the neck and shoulder area to help alleviate that muscle stiffness, pain, or even help to correct that posture pulling. But as you can imagine, you have a lot of really important muscles that live up in this area, including your swallowing muscles. So we do have to be careful doing those injections because you can get a side effect of trouble swallowing or neck weakness with those. But if we start the doses low enough and are careful, then it's perfectly safe. You can also have dystonia in your hands and legs, most commonly in the legs, if any of you guys experience that. But some people feel like their hand just kind of wants to take postures, they're not asking it to, or they get cramping in their thighs or their calf muscles, or they'll notice in their feet, especially like after exercising or while walking, that their toes will cramp and curl up. Your ankle kind of wants to turn in, or your toe wants to point down. Some people will notice when they're walking, they'll catch their toe, something like that. So all of those things can point towards dystonia. And so we will use Botox to relax those muscles in the hands and the legs, and that can really help to alleviate that posturing and that cramping and discomfort that comes with it. So that's probably the most common reason I will do it. Excessive drooling, also called sialorrhea, is another reason we'll do it. A very common problem. So people with Parkinson's don't blink or swallow as much, so we're likely to get more spit caught up here. And then another thing again, people with Parkinson's tend to lean forward. And so gravity also is a reason why people with Parkinson's drool. But it can be a really embarrassing problem. It can cause difficulty with choking. It can just, like I said, most often it's just more of a social thing. Nobody likes to, have to have a handkerchief with them and have to wipe their mouth and stuff when they're out in public. And so these injections are actually pretty short and sweet. They're just a couple injections into your spit glands. They live here in the cheek and then one underneath the jaw. And so pretty fast. But the main side effect to look out for is dry mouth. So, and a lot of people have that problem anyway, from medications or what have you. So we have to have a nice careful balance there. Another thing that not everybody realizes is always a symptom of Parkinson's is excessive sweating. So people with Parkinson's can have a lot of trouble with their part of their nervous system that regulates things like their temperature regulation and their blood pressure, as well as their sweat output. And so a lot of people will have either scalp sweating or under or armpit sweating, and it can actually happen as one of these non-motor fluctuations I was describing before. So they'll notice when their medicine is wearing off or they're due again that they'll get really hot and sweaty. And so we will do Botox for this reason as well. As you can see in the picture, we'll do it in the scalp area as well as in the armpit area. And it can be really effective to fight off that excess sweating issue. And so to get Botox, all you need to do is talk to your neurologist. Usually it does take about a month or so for the insurance piece to go through. And I tell people the injections don't kick in right away. They do take about a week and a half, about 7 to 10 days, and they do last 3 months. So they are a treatment that folks have to come back in about every 3 months to get repeated. But for some people and for many reasons in Parkinson's can be very effective and very helpful. Okay, so here's just a review of all of the things that we talked about today. And then I always include a little slide about different websites if you're involved in any, or interested in getting involved in any type of research in Parkinson's. You guys may already have the UNMC research information here, but anybody who wants to know more about that can always talk to me. And otherwise, that is it for the talk that I had for today. So I want to thank you guys and I want to welcome your questions.
Questions? Whoa, sorry.
My question is about Botox. I'm currently used Botox for about 2 years, I guess, maybe more than that. But the picture implies that you can, Botox is pointed at specific problems. So what can it also be used as a side effect? They become non-specific. Is there anything that say I'm using it for sweat gland? Can I expect all of it to be used for that, or can it be accompanying something else that there is money?
I have a couple thoughts about that, and you just let me know if I'm not answering your question correctly. So if I'm understanding right, the question, so you're receiving Botox injections, and I think your question is, what other kind of less specific side effects you might get from it, or if it would kind of address any other symptoms that you're having?
Right.
Okay. So in terms of side effects from Botox, I tell folks that generally kind of the gift of Botox is that it stays where we put it. And so for the most part, it's going to stay either in the muscle or the spit gland or what have you that we put it in. But it can spread out a little bit. And so one example that I would give of that is, say that we're doing Botox shots for your spit glands. We're doing it here in your cheek. That does live close by to some of your chewing muscles in your jaw. And so some people might experience maybe some more effort with chewing if they're getting injections here in their cheek. Or kind of a similar idea to that is some people that get injections in their eye area. I'll do them a lot for like eyelid twitching, or some people that have trouble like holding their eyes open. They can actually get like dry eyes as a side effect. So it can kind of hit kind of neighboring areas too. Some people can also get like kind of almost like a flu-like side effect from Botox, where they'll just feel kind of achy and just crummy in the days after their shot. So that's one way that it can kind of affect the entire body. So hopefully that answered your question right. The other part of your question, I would just make the point that people can get Botox for different reasons on the same day or close to the same day. So for example, if you were getting Botox in your spit gland, but then also in your bladder. So I don't do the bladder shots, a bladder doctor does, a urologist. People can get those injections either on the same day or within about a week of one another is what we tell people, to try to do them as close together as possible. So they can do it for a couple different reasons. Absolutely. Yes.
I'm interested in the weight loss effect. On Thursday, I'm going in to the gastroenterologist to have the whole tube system checked. Is there something that I should be telling the gastroenterologist that we've learned about weight loss that isn't yet commonly known? I've lost 25 pounds in about 3 or 4 months.
Well, I am very glad that you're getting that checked out. So the question is, if you're going for like an evaluation with a GI specialist or a gastroenterologist, is there anything in particular that, that you or they should know about Parkinson's disease and how it might impact that part of you? So one thing that Parkinson's can do is cause a condition that's called gastroparesis, which means that the gut is just too slow. it's just not pushing stuff through. And so a lot of people will get issues like constipation, or maybe they're not absorbing nutrients like the average Joe does. So it's really relevant that your GI doctor knows that you have Parkinson's. Another way that Parkinson's factors into weight loss that we know of, so there's multiple things. One of them is that people with Parkinson's have a higher metabolism, a higher metabolic rate than the average bear as well, or people without Parkinson's. So even when you're just sitting doing nothing, you're burning off more calories than the person without Parkinson's next to you. But then other things come into play. So constipation, people can lose their sense of smell or taste, and that makes things not as appealing. Or just the effort from trying to eat, get in enough calories can be exhausting, whether you have tremor or stiffness or slowness, or those dyskinesias. So tremor and dyskinesias also burn off more calories because you're moving all the time. And so there's just a couple different things working against you in terms of nutrition and weight loss. Hopefully that makes sense.
Gastroparesis. I have a daughter that has Parkinson's, and we've gone to the
The gastroenterologist or
the butt doctor. I gotta call him the butt doctor.
the proctologist. I believe they're called the
Yeah.
proctologists.
And they did a test because not necessarily constipated, but not moving, slow. She does a lot of enemas to get cleaned out, so hopefully the meds work.
Mhm.
Well, we went to the butt doctor and they did this test, they stick it up the wazoo
Yeah.
and see what's working and what's not. And the muscles that indicate you have to go, that we feel, she doesn't have that.
Mm.
Is that pretty common?
That I would say is a less common feature in Parkinson's, not unheard of by any means, but less common. So I would definitely also just want to make sure she's had a good evaluation for any other causes of that before chalking it up to Parkinson's. You know, I say all the time that it can it leaves no stones unturned. It does all sorts of things, but that would be one situation a little less common, I would say, a little bit, just making sure the thorough evaluation is done. But you know, you can see how that would certainly affect how her medicines work. And maybe she would be a good person for like one of the under the skin pumps or something like that. Those are thoughts. If you're
What?
one of like the under the skin pumps that Wiley.
She's done that.
Oh, okay,
Did
gotcha,
not- It did not pass muster.
gotcha, okay.
So to follow up then, the butt doctor and then the gastro guy would be the next step?
Yeah, yep. And you know, you can think of it as even if we did chalk it up to Parkinson's at the end of the day, I would still ask for their help with managing something like that for
Okay.
sure. So you're definitely on the right track.
We have two online questions. Can you tell us more about Parkinson's facial masking?
So you can kind of imagine how everything else slows down in Parkinson's. So we call this facial masking, this kind of loss of facial expression, because everything else is slow. So you're not blinking as much. Your muscles just aren't moving as spontaneously. You're not as animated or emphatic as maybe you used to be. And so most people don't really notice it until maybe they go back and they look at a picture of their loved one from years ago. And they're like, I guess they don't really, smile as much as they used to. One thing I would also just say on that is that some people also misinterpret it as like depression or that you're not having a good time when really you are. So it can have a really big social impact as a symptom and part of Parkinson's.
Is there an all-inclusive practice that Parkinson's patients can participate in at UNMC, like motor neurologist, internal medicine, social worker, PT, OT, and so forth? Not all physicians know about non-motor symptoms.
Yeah, oh, that's 100% true. The answer to that is kind of. And so at the Med Center, we do have what we call our multidisciplinary Parkinson's clinic. As of right now, that's only where we see new patients. And we will have a neurologist as well as like a physical occupational speech therapist, our social worker, and a dietitian all present in that clinic. So it is a really great space to get some education, especially if you are new to the diagnosis. Kind of another way of doing that without coming into the clinic though is, I would say like the Parkinson's.org website has a lot of that information as well, just where to start with a new diagnosis and a lot of educational tools. They're bringing the mic to you, Gary.
I don't think I need this thing, but anyway, I was at a golf course the other day, about 2 weeks ago. Lady, I was gonna play golf against, her and her husband, they, she came up to me, or we came together, and I told her, I said, I'm suffering from Parkinson's a little bit. And, she said, oh, yeah, I knew something was wrong. You knew something was wrong. Yeah, said you didn't talk as much, you didn't walk as much, you stayed more to your side, your cart, and stayed rather than go, mess around like. Anyway, she told me, she says, yeah, I know you got Parkinson's. What? How do you know that? She goes, I'm with a medical group in Grand Island, and she said, I come across all of the different things that patients deal with. And she said that you need to learn how to walk and talk about everything. Just get your brain going and get your feet going, get your legs going, and just don't let it stop you from having a good time, enjoying yourself like you were saying. And anyway, you hear that kind of stuff from people like me?
Of course, absolutely. No, I think that you're keying into a lot of really, interesting things that not everybody realizes they'll experience with Parkinson's. But I have a couple kind of different taglines that I've used, and maybe we've talked about it too. But I tell people that walking and talking is just much more difficult when you have Parkinson's because part of it is your autopilot just doesn't work as well anymore. So you have to put so much more thought into each step you take. Or if you have speech issues with your Parkinson's, like slurred speech or that thing where your words kind of trip over one another, you don't have as good of enunciation, you have to think so much more to, pace your own speech and talk clearly. And that's awfully hard to do when you're also trying to engage in a conversation, take in all of the things going on around you. So it can become a lot more overwhelming and just, some people do have a tendency to kind of sit back more in social situations because they don't know if they're going to be heard if they try to say something. Or even just trying to take in a lot of conversations and things going on all at once becomes a lot harder too. And so it's just a lot to follow. And I think that, once you and your loved ones do kind of pick up on that more, sometimes just smaller gatherings, more one-on-one discussions a little bit easier, but just knowing it's going to take you a little bit more time and you got to focus on one thing at a time, either walking or talking, but maybe not both.
How common is Parkinson's and memory loss? Could you speak on that a little bit?
It's very common. So at least half of people with Parkinson's will experience some degree of memory change. And it can be just more mild memory changes, like some forgetfulness here and there. But a smaller percentage of people, maybe like a fifth or so, can go on to have more significant memory issues or even what we call dementia, severe memory problems. Most commonly, people will tell me it's kind of more like multitasking and processing speed kind of functions. So just not thinking quite as quick or having to do things, one step at a time rather than be able to be a master multitasker, maybe like you used to be.
Yeah, one thing quickly about the masking, when COVID was going on, I wore a mask and people turned to write things with my eyes rather than the expression of my face. So I thought people were more open to talking to me and everything like that, and didn't mistreat me from my patient questions.
Yeah, you come up with an excellent point, Luke. I think that, people told me like when we would visit over Zoom, how different it was to not be able to have that kind of human piece to the interaction. And especially if you don't have that facial expression there, it makes such a difference. It really has a bigger social impact, I think, that people really appreciate.
Yeah, one other thing is about a month ago, I saw there was a study out of England about using dogs to diagnose Parkinson's, because Parkinson's patients can develop a scent off their skin that the dog can sense.
Isn't that, yeah, it's amazing what those dogs can sense. You'll have to send me that article, because I would be curious to, if they have any idea what exactly it is they're picking up on.
Any others? Oh,
I think I've read something about a possible viral effect. Has any work been done on antivirals such as ivermectin and hydroxychloroquine?
That's a great question. Yeah. So the question is if there's kind of any more established role of antiviral treatments in management of Parkinson's. I should have included that as kind of one of my hot topics, because it came up a lot during the COVID period as well. We've known for a long time that we can have kind of post-viral Parkinson's essentially. So even back in like the early 1900s, like the flu pandemic at that time, a lot of people were developing Parkinson's after that. We've seen it with West Nile and, you know, all these different things as well. And then more recently COVID. And so the kind of the long answer is that we know that there's some kind of probably immune or inflammatory thing that happens in the brain, but what we don't know is it the virus itself doing it, or is that already a process going on in someone's brain that the virus just brings out or kind of just unmasks sooner than it would have otherwise come up? And that part we don't know. Of the many things that we don't know, of course.
I got one more thing, at time.
Sounds good. I think Carla has one really quick.
Okay, good.
This is probably tied to what you just said, but there was a couple of drugs, one to Lucas and then a cough medicine.
Yeah.
That's kind of what they were for.
Yes, so Ambroxol is the cough medication, and that one actually, so it's a very common cough medicine. It's one that is available in almost every country except the US. But essentially what it does is it doesn't act so much with like a virus or an antiviral process as it's thought that the protein that builds up in the brain that kills off our brain cells in Parkinson's is this protein that's called alpha-synuclein. And the idea is that the Ambroxol as well as the montelukast, they both have a drug mechanism that is supposed to go in and kind of clear out that built up protein in the brain and stop the brain cells from dying off. It works through a specific gene that we know is associated with Parkinson's, one that's called glucose ribosylase or GBA. And so they're studying it currently in both people that have that genetic mutation and not, but it's seeming most promising to be what we call like a gene modifying therapy, or one that will help people with a specific genetic type of Parkinson's, but maybe will be something for all comers. It's actually not only being studied for Parkinson's, it's being looked at for like Lewy body dementia and other similar things too.
Is there a question?
Lady told me to talk lots, so I'm talking.
You're using the adventure we're given. I like it.
You haven't mentioned anything about exercising. There's a couple of guys that come to these meetings, and we joined a karate class and taken karate, and the exercise is excellent. And if anybody's interested, talk to me. Talk.
I love that. Well, that was another thing, actually. I'm glad you brought that up again, Gary, because another thing I tell a lot of people is you have to keep moving to keep moving. Exercise is that critical part. It protects your dopamine making cells. It gives you dopamine. It's an absolute necessity. Also, I tell people to keep talking, but also, you know, sing like nobody's listening. You know, just use those pipes all the time. Work them out.
Yodel. Sorry, yodeling.
There you go. Become a yodeler. It's never too late.
You yodel?
She might actually based on that answer.
Sound music.
Another question from the Zoom audience. How many PD patients get Lewy body? Since it is the same protein, how is that diagnosed?
Yeah, so it's the timeline of symptoms. So how do we differentiate Parkinson's disease from Lewy body dementia? Because the truth is they can look exactly the same. They can have tremor, stiffness, and slowness, but then also come with hallucinations and memory trouble. And so it's the timeline that counts. And so people that have Lewy body dementia will develop memory issues and hallucinations within about the same year that they develop the physical symptoms like tremor and stiffness and slowness. People with Parkinson's disease will have the physical symptoms like tremor, stiffness, and slowness, but then at least 5 years or so later may develop then hallucinations and memory trouble. And so really we don't expect those hallucinations and memory trouble to be early on in Parkinson's. So that's really what helps tease them apart, even though later on in Parkinson's they can look absolutely identical.
Any others? You?
Real quick, yeah. Yeah, our family was said that my maternal grandmother got Parkinson's from the 1919 influenza. So, yeah.
Yeah, that was the kind of the first pandemic, I guess, where we kind of acknowledged that people were developing Parkinson's, but same with the swine flu, same with COVID. So certainly something there, but like I said, whether it's kind of unmasking something that was already there, or if it, if there's a cause, it's hard to really prove or establish that.
I read, and I should have saved the source. That's a bad thing.
Forgive me.
That there was some experimental stuff going on about possibly the alpha-synuclein starting in the kidney. Have you heard anything?
I have not. I'm gonna look that up when I get home.
I can give you what I copied, but I didn't give you the source.
Yeah, well, and you bring up an interesting point there too, because we, for the longest time, and still do to some degree, believe that Parkinson's maybe starts in the gut. People can have constipation and other symptoms decades before their Parkinson's starts, or the loss of sense of smell can happen decades before Parkinson's starts. And so, is it in your smelling nerve, your olfactory nerve? Is it in the gut? Where does it truly begin? Is a hard question to answer. And it would help us to know that, because then we can know how to identify people earlier and start treatments earlier to see if we can either hold it off or stop it.
Any other?
Last question, what about those of us who had concussions playing football? I've read something that said that concussions might have something to do with the stroke.
Yeah, so the question is, what about folks who have had concussions and or repeated head traumas? And what does that have to do with their risk of Parkinson's disease? So we do know really well that people that have had multiple traumas with loss of consciousness can develop Parkinson's. And we have a couple different names we've called it. That used to be called like punch drunk syndrome. People that were boxers would get it. Or we know a lot about what's called chronic traumatic encephalopathy, or CTE, that we will see on the brains on autopsies of athletes, people who have had chronic head injuries. And basically just not just Parkinson's is included in that. People that have had repeated head traumas can also develop like dementia or memory trouble or other types of neurological syndromes much later in life. So just another kind of risk factor to consider.
Dr. Smith, when it comes to hallucinations, so you may have families that somebody knows they're having a hallucination and can recognize, you see people in a tree, but it's a hallucination, it's not scaring me. And I remember Dr. Suktu, I think, saying the question, does this hallucination bother you? So when it comes to something like Nuplazid or something like that, that someone takes for hallucinations, like when is it recommended to try a medication versus just reassurance and extra safety features in the home?
Yeah, and that's a wonderful question, because that is going to be so dependent on each person and each preference and situation and person that you meet. And so in general, I have a saying in clinic where I say, your symptoms bother me as much as they bother you. And that's going to apply to hallucinations, tremor, dyskinesias, pretty much anything. It's going to bother me as much as it bothers you. So we don't necessarily have to do anything about it unless it's causing trouble. And so I have some people that have the type of hallucinations that they know they're hallucinations. They're maybe kind of annoying, but not enough to justify adding a medicine. And then I have some people that they are seeing things that scare them, or they have ideas, what we call delusions, where they think that someone's outside and they got to get up and go try to do something about it, and they're going to fall or some kind of safety risk. And when that's the case, I definitely recommend treating it. And so that's when I will have the discussion about Nuplazid or pimavanserin or Seroquel. Quetiapine is the other medicine we commonly use. The kind of the drawback of Nuplazid, pimavanserin, is that it can take about 4 to 6 weeks to really start becoming beneficial. And so that's kind of the other piece that we discuss about hallucinations is, do we have kind of the luxury of time to wait for that medicine to kind of kick in and working? And some people understanding that will say, well, this is bothering me a good amount now, and let's start the medicine now, knowing that maybe in a month, month and a half, it could get worse. So the short answer is, I have to talk to each person on an individual case-by-case basis to make that decision. But generally, I don't recommend using medicine unless it's threatening safety or really causing a problem. And the other point I would make to that is I do try to get rid of things first before I add on. So a lot of the medicines you take can cause hallucinations as well. So if we can, without sacrificing physical symptom control, I will try to reduce other medicines first before adding on others.
I have a friend that's been diagnosed with Lewy body disease. Does carbidopa, levodopa help them?
We will still often use it. That's a great question. So the question was, if you know someone with Lewy body dementia, can they still use carbidopa, levodopa, or some of these other treatments? We can. So it certainly can still help with symptoms like tremor and stiffness and slowness. It's a little bit dicier in terms of side effects though, because one of the side effects of carbidopa, levodopa can be hallucinations. And so we might bring on more problems for them. The other thing that a lot of people with Lewy body dementia have as well is a lot more issues with blood pressure fluctuations. So the ups and downs, and especially the low blood pressures. And carbidopa, levodopa can worsen the low blood pressure issue as well. And so people with Lewy body dementia have just a little bit more risk using the carbidopa, levodopa usually, but they can.
Dr. Smith, we love you. And
You just love me too.
we're so happy that you came to talk to us today. It's been wonderful. And we appreciate it for sure. We appreciate those other people from UNMC too.
Yeah, say, I know you'll see them in the clinic.
We are so thankful that you are as near as you are, even though every time I come, I go, who's coming to Lincoln? Who's coming to Lincoln?
I know you gotta recruit somebody here, so, well, thank you guys so much for having us, I really appreciate it. We love to come and talk to you folks, and just amazing that you have this big of a group that meets too. It's incredible, you guys really need each other to band together.
Yeah, well, you are a draw.
Thank you, Jace, I appreciate it.
So we, again, thank you, and we will have a short, little announcement meeting and go over a couple of things. Actually, you guys are having a symposium
We are.
October 1st.
Yes, so let me give a quick shameless plug. Wednesday, October 1st, we'll have our Parkinson's disease symposium for the Med Center. So myself, Dr. C2, all of our faculty, our physical therapists, everybody will be speaking that day about everything and anything Parkinson's. I will be covering treatments, so you might hear some of the same stuff in that talk, but I'll have a lot more as well.
Thank you.
Thank you.
I think we can start signing up, registering tomorrow, if I remembered it correctly. I sent out an email, so see if you can find it so you can register for the meeting. I don't know if there's a limited number or not. I think the first year we went, there were like 1,000 people.
We're limiting to 700.
Oh, only 700 of us can go. So sign up tomorrow morning.
Sign up fast, yeah.
Opens at 7 a.m. I understand. Also, our group needs a treasurer. And on your table are 3 pieces of white paper with blue ink. And it tells you what the treasurer of our group needs to be able to do. So please take a look at that list. I won't go over it, but please take a look at the list. And if you or you know someone in your family or whoever, let's get someone signed up to help us. We need it. We need the help. Okay, so we covered treasurer. We've covered the meeting on October 1st. And are there any other announcements that any of you have? Our next meeting will be September 28th, And I don't know how many of you've heard Dr. Alley. She's a pharmacist. She's with UNMC. And she's also a delight. We've got a wonderful plan for her to join us next month. Need to thank Gunter and Sally and Jim for all they do to make this possible. A couple of other things. I sent out an email. Dr. Ray Dorsey and Dr. Okuman are really big on the problem of things in the air, things that we smell, things that we're exposed to. And I haven't started the book yet. I think Rich has. But once we're finished with it, I want to donate it to the library. And then if you would like to read it, or you can, of course, get your copy, but just so you know, there'll be a copy around. Okay, last but not least, Carla here has been invited to represent our state at the National Parkinson's Advocacy Forum. And this is September 8th through the 11th, and it happens in Washington, D.C. So, of course, she's very active in the Parkinson's Foundation, and they have invited her to come. And if I understand correctly, they meet with the Congress and promote the needs for those of us who are affected by Parkinson's. So let's give Carla a round of applause for her. You know, she will represent us well. That's wonderful. Okay, now if you'd like a refreshment, Sally's got a nice table set up. Also right by that table is the library table. Take a look at that. And then we will divide into care partners and those with Parkinson's. Hope to see you next month.